insurance has about 20% administrative costs. So that's your administrative waste. But this is also the opportunity for fraud and abuse. This is where all the backroom deals take place in that mess. That spaghetti thrown on the wall is where all the backroom deals take place that end up with that fine print that results in surprise medical billing. And when you leave the hospital, you get a bill you had no idea that you were going to get. And it's abuse because that same negotiation is fraudulent and abusive in that it's a mafia model of business operation. They're pricing their product. That's what this is. It's a financial scheme, okay? And they are pricing what they do based on what our lives are worth to us, not what it costs them to provide that service. And that is extortion, right? That's, hey, that's a nice kid you got there. Be ashamed if you didn't buy this overpriced insurance product that's going to save their life. And you don't have to look very far for that. I recently posted an article from Vox, VOX, about how insurance companies now are threatening to not pay for emergency room visits that they think weren't warranted. And so who's going to get stuck with that bill? We are. We all are. So this is not just administrative waste, it's also fraud and abuse. And that's why we need to go to this type system yesterday. So there we go. So what's the outcome of this? And, you know, still, even how does it relate to what it is we're living through now? This pandemic, this public health crisis, this strain on everyone at this point, economic, social, the disaster, the social disaster that this COVID-19 has been for us all, and some worse than others, of course. What we have are a few basic things that really, you know, are principles that we should all recognize at this point. And you don't hear them talked about nearly enough. You have big insurance and big pharma still calling the shots. They are still setting priorities and access. I use the term calling the shots. Maybe the one thing that they're not calling is the vaccine shot. That's actually probably is the one part of COVID care at this point that is universal, that they're not asking for money up front, you know, and they're not denying care, generally speaking, for a vaccine. That's universal. But what about all the rest of the COVID care? What about testing? What happened to the idea of universal testing and contact tracing? Remember that concept? And that is why every other country in the world, all these other advanced countries, performed so much better when they were challenged with this pandemic than we did, because they were able to do universal testing and contact tracing when we couldn't. And, you know, and now they're a little behind on vaccinations when we're ahead on that. But still, their numbers are so much lower as a result in terms of deaths and all of the prevalence of disease. So that means, you know, again, big insurance, big pharma have set the priorities and access. We have healthcare deserts. We have disparities in care, especially in the inner cities and in rural areas where it's not marketable, where just, you know, commercial interests can't, you know, sell their products. They just don't sell in those areas. And therefore, no resources are allocated to them because, again, they're commercial interests. You have these public-private partnerships. Anybody here like that term, public-private partnership? Not me. To me, it sounds the same as privatization or profitization. And that's especially if you look at a time of public need, especially extreme public need, like a public health emergency that we're all living through right now. You have a private entity or commercial entity taking money and resources away from the public need. So if we need something, we're not getting it because somebody's taking resources and filling their pockets with it. So public-private partnership really is another name whenever you hear, somebody I know, it's like a favorite term for people like Mike Pence, loves that term, public-private partnership. Think profitization. Somebody's making money off that, which is immoral. You have all of the, whoops, sorry about that. You have the prior cutbacks to social services that, or what we call wraparound social services that included things like shelter, adequate shelter and sick leave, and just being able to pay your utilities and have food on the table. All of those things were actually in the process of being cut back, of course, under the previous administration. So that set us up for these terrible outcomes as well. And but we can't blame it all on one administration, because we need a healthcare system that includes all of those wraparound services, like a holistic approach. And if you look at that actually in more detail, that does exist in the language of these Medicare for All bills, both federal and state, and also very importantly in the Green New Deal. Green New Deal includes Medicare for All as well as all these other wraparound social services, so that health outcomes are better. What's called social determinants of health are improved. Right now, what we have is wellness for the wealthy. We all know that. We've seen the inequity. It's the vulnerable populations that are being hit hardest. And that's especially true in our BIPOC communities, our Black and Indigenous people of color, but it's also true in our unhoused communities, the unemployed, folks on fixed income, or if you happen to be detained or incarcerated, of course, very, very vulnerable and with poor health outcomes. None of that can get fixed with the commercial interest being in charge of payment. And of course, the very dire global temperature rising situation. To keep in mind, again, something you don't hear much is that this novel coronavirus is just one of many to come. And that's not me saying it, that's climate scientists saying it. As global temperatures rise, we're going to see more viruses, other kinds of contagions and pathogens, as well as, of course, environmental toxins, traumatic weather displacements. All of that is going to affect our health and our ability to survive. So what's to do here? The to-do list is basically these three things. Federal legislation, state and local efforts, and then coalition building. So number one, the federal bill, which has, most of us here know the history going actually even way back, all the way back to FDR or Teddy Roosevelt, even in more modern times. John Conyers Jr. of Michigan, of course, the dean of the House, I think they used to call him, or the lion of the House, one of those expressions. He carried a HR 676 in the House. I think it was in 7 sessions of Congress over 14 years. And you know, it never got to a floor vote. Had lots of co-sponsors, never got to a floor vote. Didn't matter who was the speaker at the time. The most recent iterations have been HR 1384 from Pramila Jayapal, after Representative Conyers resigned from the House and then passed away. And then now Pramila has reintroduced it again with co-author Debbie Dingell of Michigan, and that is HR 1976. That's the one we'd like to get Anna Eshoo to sign on to, and of course, Nancy Pelosi. In the last session of Congress, we had more hearings on this bill, or more hearings that covered this bill. They covered other bills as well, but it was talked about in more hearings in Congress in the House than it ever has previously. And so I think Speaker Pelosi is actually, more open to the idea than she's ever been. But we do need more co-sponsors on the bill. Representative Garamendi is not on the bill. So there are quite a few folks who are kind of close in the inner circles of leadership. Richard Neal is not on the bill. We did get Frank Pallone that's here from, he's very important, of course, chair, I think, of the Energy and Commerce Committee. And he's on the bill this year. So we are expecting hearings, not sure when at this point. And we're expecting Bernie Sanders to reintroduce the bill in the Senate, which he has not done yet. They've been kind of preoccupied with the filibuster, of course, and Mitch McConnell still able to shut down everything that isn't in reconciliation. So the other bill on the federal side that folks should know about is Ro Khanna's HR 3775, which is the State-Based Universal Health Care Act. And that one enables states to move forward with their own single-payer universal health care systems, like California is trying to do now. And that one actually is a reintroduction as well, and was previously carried by Pramila Jayapal. And so when she went on to the Medicare for All Act, she kind of turned it over to Ro Khanna. We do need more co-sponsors on that bill as well. And I'm happy to go into that in more detail if folks want to. At the state level, I'm sure everybody here has heard of the most recent introduction of a California single payer bill, which is AB 1400 from Ash Kalra, Northern Cal Assembly member, and it is terrific. It provides an opportunity for all of us who are trying to make this happen. If it can't happen at the federal level, we want it at the state level, with the idea that, if it could happen in California, it could spread across the country, much like happened in Canada, where it started in Saskatchewan and spread across their country. And especially California being the big dog, as goes California, so goes the country. The author and has more support, I think, than any single payer bill that's been introduced in the state has had going into it. It has some 7, I believe, co-sponsors or co-authors in the Senate, and 11 co-authors in the Assembly. That's a lot, 19 co-authors. And so that's pretty darn good. But even with that much support, he felt he did not have enough support to push it through the committee process this year. He's turned that into a 2-year bill. So by the end of this year, he's hoping to have enough support to push it through the committee process in the next calendar year. And that means also that it allows time for what's known as the Healthy California for All Commission to catch up with that bill, with AB 1400. The Healthy California Commission came out of the last attempt, which was SB 562, and what was agreed upon by the legislature was to set up a commission to outline a a plan for developing a single payer system in California. So that commission actually is meeting now monthly. Its next meeting is tomorrow afternoon, July 8th at 1 o'clock. If you go to their website, which I can post in the chat after this, it's through the California Department of Health. You can, or just put in Healthy California for All Commission in a search, and you can register to watch that hearing tomorrow afternoon. But that is their commission, is to develop the system. And that's will allow then the members of the legislature to see a plan, a blueprint, by the time they start discussing it in the committee process in the next calendar year. And they are committed to giving a report to the governor by the end of this calendar year. So all of that is kind of very recent development. They actually were on hiatus when COVID first hit, which was a source of a lot of consternation to a lot of us, because here we are in the middle of a public health emergency, and they kind of shut down their commission proceedings during that time. But thankfully, they've kind of they got the band back together. So the commission is now meeting once again. The other thing that I would say at the local level is that these things trickle up, and it's really important for all of us to ask either sitting school board, city council members, county council, and boards and supervisors, ask them what their position is on a single payer Medicare for all system, because if they don't have one, they need to get one. They need to know that their city, county, school district is going to save incredible amounts of money. I mean, it's not just good for the community, it's good for their district, whatever that is. It's healthy, happier workforce and an economic boom at the local level. And that trickled up. Right now, we have a number of cities who have signed on to these Medicare for All resolutions. We have a group known as Mayors for Medicare for All. That's actually being headed up by Mayor Robert Garcia in Long Beach. You might have heard of him. He's a terrific, very progressive mayor, and in the city of Long Beach, and doing a lot of great things there. He has started this group, Mayors for Medicare for All. So you could look that up as well. But I think we need to challenge all of them in every setting that we can and say, what's your position on, on Medicare for All and the Green New Deal, for that matter? I mean, it is kind of the think globally, act locally concept. And then finally, join all of these groups, all of these coalitions, all these terrific groups. Mine is, of course, we want you to join us, Progressive Democrats America. But, all of these champions for the cause, National Nurses United, which is California Nurses Association here, the Labor Campaign for Single Payer. Those of you who have questions or concerns about unions and the labor movement, how they fare in a single payer Medicare for All type system, that's a very valuable resource. Healthcare Now is a national group advocating for single payer, both federal and at the state level. NUHW, the National Union of Healthcare Workers, has really stepped up recently, and especially here in California, become a major participant in our state coalition. And of course, NUHW is more expansive than just nurses. They're also the clerical workers in hospitals and clinics and technical people. So it's terrific that they're involved in this as well. PNHP, if you've never been to their website, I highly encourage you to go. I know you said you had Dr. Song here present previously. Paul Song, he's on the national board. PNHP, very interestingly, is a group of MD PhDs who founded it based at Harvard Medical School. And so they're quite academic oriented, have really nice graphs and tables and, you know, those kind of wonky presentations that they do a lot of really good, you know, kind of public presentations on. So that's a terrific resource. I highly recommend that you go there as well. And I have used their stuff, stolen with permission, for years. You know, for my talks as well, and really valuable resource. Just a couple others. Public Citizen recently has stepped up in a big way. They're now kind of like the lead citizen group for Pramila Jayapal's efforts, and they kind of led the rollout of the reintroduction of HR 1976. So great to see them. The Center for Popular Democracy, that is Adi Barkan's group. Be a Hero is part of their group, Center for Popular Democracy. And Adi Barkan, of course, is the tremendous activist in Santa Barbara who has ALS, and, you know, has artificial voice, and, you know, is such a terrific advocate. And I think he was even possibly singularly responsible for why Nancy Pelosi did allow mention of the Medicare for All Act in those committee hearings in the last session of Congress. Hopefully she'll do it again as a result. One Payer States is a group that collaborates on the different states, kind of shared best practices. So here in California, we have a group, Healthy California Now, that is kind of the coalition statewide. There are groups like Single Payer Action Networks and Healthy California for All, Healthcare for All across the country chapters. As well. So all of those kind of coordinate through the OPS group, One Payer States. You could put that in a search as well. And then kind of the newest organization that's doing a lot of good work is DSA, Democratic Socialists of America. And it's terrific to have them on board for this too. So I would just end with, with this famous quote from Dr. King, who of course was way, way, way ahead of his time. Of all the forms of inequality, justice in healthcare is the most shocking and inhumane. And a lot of us have adopted that famous quote of his because it's just so true, and couldn't be more true than what we've all lived through. I think we all have some degree of post-traumatic post-COVID, post-traumatic distress now, but it's well worth remembering and paying attention to. So thanks. With that, I'm happy to take questions or comments from the group.
All right. Well, I'm going to, as chair, I'm going to take my privilege and ask the first question. But I want to say, if you'd like to ask a question, please raise your hand, particularly if you can do there we go. And we'll take people in order. Please ask one question. You can come back in line and ask a second one, but one question. So I want to start with, you had that beautiful graph that was the savings by company size, but that was from 2004. Is somebody doing an update to that? Because that would be tremendously good.
Great question. Thank you so much. And I haven't seen it shown exactly the same way recently. I think Dr. Song has one from not too long ago that's very similar. I call it the upside down horseshoe. By the way, it's kind of like the down-going thing, because the axis of the line, remember from algebra, the axis is downward, and that's because it's savings. So small, medium, and large size business groups all save money. The medium size, not as much as small business and big business. But the other point about that is that, people like to say, how are you going to pay for it? Right?
Right.
Okay, Medicare for all sounds great, right? All the people get all the care. How are you going to pay for it? So every time it's been proposed, including, that back then in 2004, a financial analyst group proposes how you're going to pay for it. Okay, they did that. This last time for SB 562, we had a group out of UMass Amherst called the Perry Group. They had a proposal. They had multiple proposals how you're going to pay for it. Okay, but this group, the Lewin Group, had a proposal to pay for it, and those were the numbers that they generated, when they gave it that way. So I mean, you can try and tweak it, any way that you want, and maybe you could tweak it so that the medium-sized employer groups, would actually save more money than that. But the point here is that all businesses save money, and that's truer now because all of those costs to businesses have gone up in the meantime. So I wish I had a newer graph of that for you. I will keep my eyes peeled for one and send it to you if I see it.
That would be really good. All right,
Right.
first question up then is Greg, and followed by Marcia and Elsa.
Hi, Greg.
Greg, you're still muted.
You are muted, Greg. You have to unmute.
Greg, you need to unmute.
There you
There you
go.
Good. Dr. Bill,
Yes.
before COVID, the country was spending on healthcare a total of about, not quite, but close to $4 trillion per year on healthcare.
Yeah.
And I calculated several times already that of those 4 trillion, about 1.5 trillion were paid by the federal government through various taxes or subsidies. Okay, so that leaves $2.5 trillion that are not paid by the government. And the question is, who in this single payer system is going to pay for that $2.5 trillion?
All right. Well, terrific question. I'm not sure, about your calculation, because what I've heard is that it's actually much higher in terms of total government spending on healthcare. It's closer to about 70% of total government spending. So maybe it's state and federal taxes that we're talking about, and would also include, I'm not sure that you included, like the VA, Native American Indian Health Service.
Yes, I've included all of that. Yes.
Yeah. So,
well, it's not 70. It's not more than about $1.5 trillion. I can tell you. I would like to have a private conversation with you. But
sure.
let's say it's even a little more. But
Yeah.
4 minus 1.5 is 2.5 trillion.
Yeah.
And
well,
who is going to pay for that?
Yeah.
In your single payer assumption.
Well,
okay,
yeah, I would say the same people are paying for it now, meaning you and me. Okay, we're paying for healthcare, but we're not getting it. And this is my, again, I'm not a wonky guy. I'm not an economist, although 200 plus economists say we can do it more efficiently, save money and save lives, right? That was that letter that we got in 2019. I think it was 250 economists all signed on to this letter. Now, I don't know, maybe economists are a dime a dozen, you can get them to sign on to stuff, but they all looked at all those numbers. They crunched those numbers.
Well, what is
I
your
know.
answer? What is your answer?
Well,
Greg,
my answer is it's not pie in the sky it's pie shop pie. Okay. Or I don't know. You guys have Marie calendars up there? I always use Marie calendars. Okay. It's Marie calendars pie. If you go to Marie calendars and buy a pie, okay, and you take it home and you open the box and a third of your pie is gone when you get home. Are you mad about that? Would you be mad at that point? Because a third of our healthcare pie is being stolen from us right now. A third of our healthcare pie is going to waste, fraud, and abuse. We're just talking about recovering that third of the healthcare pie, a third of every healthcare dollar that's currently wasted on administrative costs and the fraud and abuse. We can do that. We can eliminate that waste, fraud, and abuse. That's what the economists are telling us. We can recover that third of every healthcare dollar. And here's another picture for you, Greg. And I appreciate your wanting to account for these things. But what happens when you recover that third of every healthcare dollar that's currently wasted, and you put it into healthcare that takes care of people? You have a healthier, happier workforce, right? But you also create a whole lot of jobs. You build more hospitals and clinics. It's an economic expansion model. It's job stimulus. And that's a third of one of the largest sectors of the economy that exists in this country, which is healthcare. So it's a big boom. It's an economic boom and not a liability. But yeah, that's, I'm not an economist, but that's what the economists tell us.
All right, so the next question comes from Marshall and then Elsa.
Thank you. Great presentation. This is sort of a follow-up to your trickle up comment. I agree with it because we need to have people that have the ear of the politicians that can make policy and get things passed. So, we understand clearly why big pharma and insurance companies are opposed to this. They're going to lose that 20 to 30% of the pie. So my question is, we have some people that refuse to accept the economic clear data on cost benefit of Medicare for all and how it outweighs our current system, despite the incontrovertible financial evidence. What can we do to get them to be so recalcitrant so they can participate in getting those politicians that they have the ear of and influence of?
Terrific question. I love that question. So what gets them to not refuse to look at the science, follow the science, to look at the actual information? And to me, it's another name for this is political will, right? What we have I know our friend Michael Leidy in the movement, he likes to say we've won the policy argument. Now we need to win the political argument. So we need political will on our side. So what makes up political will? In this country, there are two main factors. And who did I hear say this recently? But somebody, a very, very wonderful person said what I'm always thinking. That's why I think they're wonderful. Two main factors. What do you think they are that moves politics in this country? What would you say? Marshall, you still there?
Yeah.
Or anybody want to chime
the
in?
two main factors are money
Yep.
and pressure of constituents.
Votes, right? Votes.
Yeah.
Money and people, or votes. And so that's what gets the ear of politicians, is money and votes. And I look at it as political winds blow one way or the other. If we can make the political winds blow towards the people, and every once in a while we do. I mean, Bernie Sanders was doing that, right? He was going out everywhere I was up there in Oakland and Santa Cruz for those rallies that he had, during his primary campaigns and stuff too. So, if you can blow those political winds the way of the people, then you can make those local politicians go that way too. To me, that means raising awareness, more town halls, more rallies, movie showings, even on COVID, there's so much of that you can do. On Zoom during COVID, there's so much of that we can and have been doing. You guys are doing it right now. This is job number one right here, just showing up to this meeting and having this discussion. So to me, that's what we need more and more and more of. Substantive issues, discussions that move this agenda, in the way of us and away from the money. Great question. Thanks.
All right, next is Elsa, and then Susie McKee.
And you are muted, Elsa.
The Martin Luther King quote you showed in the last slide was a quote that I had put into a resolution that we passed, and a resolution in support of it that we passed, and that Ashley took to our central committee for San Mateo County to have them pass. The resolutions committee sent it back, made a couple tiny changes, including grammar, which was not right. Theirs was not right. But they wanted to take out that quote. And it's the one thing we laid down on. We said, no, that's powerful, we need it. And when I presented it at the committee, the meeting, I chose to, knowing that was controversial, I chose to use that in a very short speech. And you could hear audible gasps in the room. The fact that Martin Luther King, facing all of those awful issues, would point to that as the most egregious. And so thank you for using that also. My question though, sorry for the preamble, my question is, we recently met a very interesting fellow named Dr. Jason Wang, whom I've talked to you about, who's at Stanford right now, but was the project manager for McKinsey unfolding the Taiwan healthcare system. And when he met with Anna, he's written a number of articles, both of which actually were about an integrated database. And when we met with Anna said, okay, I have 15 minutes. I know we're talking about single payer. And I said, no, Anna, actually, we're talking about an integrated data system. Sorry, integrated data system was his phrase. And so my question is there some, and he was able to frame it that way, and clearly the only way you get there is a single payer system, interestingly, but it was different language from single payer system. Do you think we might be in need of slightly different language at this point to try to get away from some of the garbage that a lot of people have been throwing at the idea?
Thank you so much. It's like you put that, it's like T-ball, you teed that one up for me. Elsa, we did not talk about you asking me this question, by the way, ahead of time, but I actually neglected to bring this up while I was using my COVID slides, but COVID is the best example of that, and the need for integrated systems, information systems, in dealing with healthcare, generally speaking, but especially at a time of public health crisis. And that's why another really important reason why so many countries have done so much better than we have. I mean, we all want to look at Donald Trump and say, oh, what an awful person. Oh, so many people died because of Donald Trump. But they also died because we don't have integrated health information systems. And they do in South Korea, and they do, in Canada, and they do everywhere else in the civilized world. Why don't we? Anyone know why?
Because we're not civilized.
right? I'll bet Linton
Health
Heidekoper knows.
insurance?
That's right. Health insurance companies have proprietary rights to the information at hospitals and clinics all across the country. They will not share that information. And they have proprietary rights that exclude us from being able to correlate and collate that information. So that's what we're allowing with our corporate welfare. It is health insurance companies primarily who have blocked that production. So Elsie, you're absolutely right. COVID is the best example of that, that we need new languaging to say, we're not going to take this anymore. You guys have been, we've had the fox in the chicken coop long enough, or the vampires in charge of the blood bank, literally, at this point, long enough. It's time for them to go so that we can be a civilized country as well as an advanced one too. Great question.
So are we changing the
Right.
language?
We just did just now in this group. Thank you so much, San Mateo County DFA, for that.
So we've got two more. We got Susie McKee and Nancy Crampton.
Sure.
So this is kind of dovetailing on what Marshall asked about, but I've seen that slide before about us versus the rest of the civilized, quote, civilized world.
Mhm.
But I mean, do you show that? I mean, do other people see that are in government? And how can we boots on the ground take that kind of information to people? I mean, or do they? I mean, I've seen it before, so they've probably seen it before. So I just wonder what we can do practically to get some of this information out there that's so startling if you haven't seen it, and startling even if you have seen it.
Great question. Thank you so much, Susie. I'm happy to give a presentation to any group that'll have me on Zoom. Like that is the wonder of Zoom. I don't have to get in my hybrid vehicle. And, I was in one in New Jersey the other day. We met with Andy Kim, who's one of the members of the Congressional Progressive Caucus. My own representative here is Katie Porter. Don't we love Katie Porter, right? Well, she loves Andy Kim, but he hasn't signed on to Medicare for All. Don't know why. She praises him. She says he's not on board with everything she is, unfortunately. But, we can take that information anywhere across the country in a meeting like this. PDA, Progressive Democrats of America, we have what we call liaison teams that meet with congressional staffers. If they won't set up a meeting with their member of Congress, we can meet with their staff members. So I'm happy to present to a staff member, any member, of Congress with their staff. For that matter, I'm giving you, with permission of the author, this PowerPoint. So you're welcome to spread it all you want too. So it's out there. It's up to us then to put these things together. One thing I might mention, has everybody here in the room seen the movie Fix It Healthcare? Anyone? It's okay. You can raise your hand if you have not seen the movie Fix It Healthcare. This is family, right? So it's okay to admit it. But it's a wonderful film. And I would be glad to come back in Zoom or in person. If you're having in-person meetings, I will get in my hybrid Toyota and drive up there and stay with my sister Amy. We should all see it together. It was a film made by a middle-sized business owner in Western Pennsylvania, kind of Pittsburgh area. And he figured out that he would save a tremendous amount of money for his business, and his employees would be so much better off, and himself, of course, if we went to a single payer system. He said, I've got to invest some money in that message. And he produced this movie, Fix It Healthcare, which is just fantastic. So if you all haven't seen it, you can actually put that in a web search. I think it's fixithealthcare.com. and watch the movie online if you'd like. But it's even better to watch it as a group and have another discussion like this, because it's very down to earth. It talks about tremendous benefits to business as well as communities. And, you know, there's lots of other great films, of course, out there. I think, Susie, right, when we do that, when we share that kind of information, we get smarter about it, and we can have those discussions with friends and family and coworkers, neighbors that elevate this discussion, and that will make the change that we're looking for.
But the only thing is that we really need to know what's keeping people, like the person you talked about, from going with it. What is it? Is it just some kind of pressure from their constituents, or is it something
Political
more?
wins.
Huh?
It's the political wins. They're blowing the way of the money. We have to make them blow the way of the people.
Well, I mean, there's always going to be money blowing in different directions, but yeah, I know that's true. But I mean,
Information,
specifically, that's all.
right? Raise
So we all
awareness,
know that money is coming out of big pharma and big insurance,
right?
and it's not to their advantage to go
Right.
to Medicare for all.
Right,
All right,
So they're
last
paying them
question
off.
up. We've
right.
got Nancy and then back to Elsa. Nancy Crampton.
Nancy's going to be Jim.
Oh, there we go.
Nancy's-
Sorry.
Nancy's deferred to me. I feel very lucky. This is Jim. As a kid, I always remember when I would get sick, looking out the window and seeing a beautiful Cadillac pull up to the house and a doctor come in to take care of me. I felt very proud and respected that I knew he was one of the highest paid people in society, and deservedly so, because he'd gone through a lot of education. Today, we have doctors who are, in my opinion, much less paid than the executives of healthcare organizations and pharmaceutical companies, led by people with far less education and probably mental skills, but they played the game. How do we get the doctors to come together and exhibit a little bit more power in this conversation as well, to help fight against this? Because they deserve to be taken care of, and that's a key to part of our solving the problem.
Right there with you. Thank you. Actually, I don't know if you've been to PNHP website, Physicians for National Health Program, or health plan website, pnhp.org. They've got great pieces on that. Of course, they were founded by physicians, but actually you can join without having to be a physician. It turns out that in this country, we horribly underpay our primary care providers, and we horribly overpay our, in particular, our surgical specialties.
Yeah.
Now, not all specialists are horribly overpaid, but especially surgeons. And there's a reason for that. And that's because they are paid as what we call fee for service, primarily. They're not usually paid so much for an office visit or a consultation, you know, like non-surgeons are, okay? They're usually producing, you know, almost like a mill, cases that are coming out of the operating room kind of thing. And that's who's been protected by the traditional medical lobbying arm, which like the AMA, and in California, the CMA. Here's a figure most people are shocked to hear. What would you guess is the percentage of doctors in America who belong to the AMA? What's your guess?
Don't they all?
25%,
How much?
25%.
Nope,
60.
nope,
I
too high.
bet 60.
I don't know percentage, but I'm going to say all the specialists, not
15,
primary care physicians.
15.
Oh,
Only 15% of doctors in America belong to the AMA. Only 15%.
Why?
I never belonged myself. Never have. I always thought they weren't looking out after my interests. And I was a specialist too, as an emergency room doctor. Okay. Not a surgeon. I didn't charge by the stitch. I never cut anyone. I only sewed up people. But, you know, but that's what I always said. You know, it's like Like they weren't looking out after my interests. Why should I belong to that group? Fortunately, there's some newer blood coming into, I guess you can use that word, that term, blood. Newer, physicians coming in are more, socially oriented, less greedy probably, and looking at why are we underpaying family doctors, pediatricians. It's kind of like the way we underpay teachers. We horribly underpaid pediatricians. We just don't value our kids, and we horribly underpaid pediatricians, just like we underpay teachers in this country. We also underpay our mental health workers, psychiatrists and therapists, horribly underpay them. I can tell you in Canada and the rest of the civilized world, where the public decides, they pay them much better. And then people go into those areas of practice, in primary care areas of practice. They're better supported. They have a better lifestyle. And yes, when you're, an ophthalmologist in Canada only makes, $650,000 a year instead of the 5 million or whatever, and then owning 5 Ferraris, that they do in this country. So, I mean, that's it is horrible. Now, I can tell you also that by and large, physicians will be paid as well, and a lot of them will be paid better under a Medicare for all system than they are now. So, but I totally agree with you, and that's actually in the legislation, and PNHP is a great resource for that.
All right, Elsa, you got the last question.
Thank you so much. Am I unmuted? Good. Thank you so much. Adding to that comment, Dr. Bill, let's see, Congress, which receives election contributions from the healthcare world, assigns to the AMA, which has only 15% of docs in it, assigns to the AMA the responsibility of choosing physicians, all of whom are specialists, to put on the congressional committees that decide pricing for Medicare and Medicaid, for CMS. It's the specialists who have therefore driven their, and you can put cardiologists in there too, driven their price tags up incredibly and dampened all the primary care physicians, all the ones that you mentioned. It is outrageous. And yet it's because of that AMA link. And if we could get publicly funded elections at a far lower level of spending, and give everybody a little minutia bit of the airwaves, we could have our legislators spend their time talking with us and legislating, debating on the floor of the House and the Senate, and not 70% of the time picking up the phone. But I actually had a question in this. Oh, no, actually, it all came back to money in politics. The big issue with money in politics is that all of those contributions, which are greater in the healthcare world, they are greater in the pharma world, they're greater than the money that pharmacological companies today put into R&D. That's the really shocking part. That all goes into campaign contributions. It is minute relative to their profitability. Since we now put $30 billion a year into NIH funding, and NIH does now the vast majority of the basic R&D research, which then funds, which then produces.
Elsa, is there a question?
Let's see.
We're on our time, so
sorry.
is there a last question?
No,
Or
you're right. I'm sorry. I think I was going to make the money in politics. Shame
Well,
on me.
can I just add to what Elsa
You
was
bet.
saying? So
You bet.
thank you again for teeing up one more issue that I didn't bring up in my presentation,
Make
which
it
is pharma. And pharma, of course, I mean, there are a lot of Republicans on board now with going after pharma, but they are even more egregious in terms of their unscrupulous practices. The waste, fraud, and abuse part is, of course, worse in pharma. They are the lower hanging political fruit, even that should be gone after. And I would just leave you with my favorite example is the EpiPen, right? EpiPen. Everyone's familiar with EpiPen because it was, used for emergencies, for allergic emergencies. Okay. Everyone knows that the retail cost is about $300. I think it's $350 per dose, and they make you buy 2 at a time. So it's like $700 that you have to fork out for 2 doses, which, you might want to have a one in your car, one in your boat, one in, if you travel, stuff like that. Okay. And it's a liquid. So there's planned obsolescence. It doesn't stick around very long. So you have to replace that. Okay. What do you think it costs pharma to make that product?
$3.
That's close. I
50
usually say,
cents, 50 cents a
Okay.
dose.
now you're kind of out overboard. Even I won't go that far. I usually say about $1.25. I'd say 25 cents for the epinephrine, which is adrenaline. It's
Right.
been
That's what
around
I meant.
forever,
Yeah,
right?
yeah.
Right?
Yeah.
20, I'll give them 25 cents for the adrenaline and another $1 for their fancy injector, which you really don't need. You could give it the old fashioned way. Remember those little glass syringes like they always used in those World War II movies to inject morphine right through your clothes, right?
Yeah.
You could give one of those. You don't need that fancy auto injector thing that they have. So, but anyhow, let's give them $1.25. Let's add a little profit to that. Okay, let's make it $5, $10. Why in the hell are they charging $350 for something that they should charge $5 or $10 for? That to me is egregious. It's based on what your life is worth to you, not what it costs them to make and distribute their product. And and we need to go after
And-
those.
And the follow-up on that is, will your insurance cover it? And my insurance company is a nightmare, and they don't want to cover an asthma inhaler. And we're talking generic.
Same thing with that.
Yeah.
Well,
Anyhow.
they're in
I'm
the
gonna say-
business, they're in the business of refusing to pay if they don't have to. That's
right.
their business model.
Exactly.
Yeah.
Bottom line.
So I've gone over time, but I want to just thank you all once again for having me and for being mindful, aware, and active on issues like this. And appreciate it so much. And I would love to
And-
come back if you want to see that movie or anytime for that matter. So.
And I
Really
wanted to
a
say
pleasure.
thank you, because we have all really enjoyed this. This has been educational and gives us information to keep working on. So thank you so much.